Good morning to all, and Happy New Year to everyone. And so I begin this year's first presentation. The title is Plasma Immune Signatures After Pediatric Liver Transplantation. The only disclosure I have that I'm not an immunologist. Whatever I'm going to present here is something which I've read and seen people do. So the outline would be I'll touch some few slides on transplant immunology because without understanding what is transplant immunology, you cannot understand how do you monitor immunity post liver transplantation. So immunology started with transplant immunology because when they did the skin grafting experiments in 1900s, that is how they could understand what immunology is all about. So the major players, but not the only ones, are HLA, the lymphocytes, the B cells, and the antigen presenting cells. Not in this sequence as such, but I'll tell this later. So what is HLA? HLA is nothing but major histocompatibility complex that is known as the animals. It's nothing but a protein which is present on your cells which helps your body determine whether it is self or non-self. So you have these self HLA molecules on your every cell of your body, but if you have non-self HLA molecules, your body will reject it. So what are the examples of non-self HLA molecules? Anyone? It's your transplanted organ or some incompatible blood products that you are giving to your person. So these are the classical example of non-self HLA molecules. But on the other hand, you may have cells which may not have any HLA molecule at all, which will still be rejected by the body. So what are the examples? Infections, viruses, bacteria, they do not have HLA per se, so the body will reject these also. So the major function of HLA is that it acts as a cascade or a scaffolding to present the antigen, non-self or self antigen, to your antigen presenting cells, and whether it is a self or non-self, the body will decide what to do with it. And they are basically of three classes, majority which we know is MHC class 1 and class 2. MSC class 1, I'll show this in this way, yes. So MSC class 1 is known as a cytosolic pathway. That means it will take care of only those organisms or things which are present inside the cell, like intracellular viruses or something. So it will take up this virus, enter into this proteasome. These proteasome will process these peptides, which with this transporter associated peptide will form a complex with the MSC class 1 and it will go to the cell surface. And this is important because proteasome in liver transplantation or in any liver organ transplantation, they are pathways in which you can inhibit these proteasome inhibitors like bortezomib, etc., which can subsequently decrease the antibody production, not primarily in T lymphocytes, in B lymphocytes also. And the class 2 is predominantly for the CD4 T cell, which is known as an endocytic pathway because it senses whatever the antigens which are present outside the cell. It will take this antigen inside the cell, process it, again complex it with MSC class 2, and this MSC class 2 will go to the cell surface. Second important component is the innate and adaptive immunity. Innate immunity means that it does not know whether the antigen is self or non-self. It's a non-specific response. Adaptive is, the word adaptive means that once it re-encounters that similar antigen, it will have a better or a more profound immune response to that. So it is adapting. So innate immune system is constituted by the classical antigen presenting sites like dendritic cells, macrophages, natural killer cells, and the granulocytes, which are composed by neutrophils, basophils, and eosinophils. And the adaptive is constituted by B cells and T cells, and NK T cells or gamma delta T cells are somewhere in between these two. So the basic purpose is that once you have any exposure, say for in a liver transplant you have some mild or major degree of ischemic reperfusion injury in living donor or deceased donor. So that acts as a precipitant for the body to start acting. Body senses it as a danger because there is an injury or inflammation in that area. What it will do, the innate cells, the antigen presenting cells, the macrophages, they will sense it using the pattern recognition receptors or the PAMPs or the DAMPs like TLRs. It will get activated and it will try to control that infection in that area. Simultaneously you have to realize, so this is the reason whenever you have a secondary infection like CMV or any other infection, it can always precipitate your rejection, because that is the reason, because this is the innate response of body to any infection, because it predisposes or increases the sensitivity of the local liver to that rejection. And the second aspect is, this is the soldier inspector interactions. The innate cells, it will take up the antigen, it will process the antigen, and it will show it along with your MSC complex or HLA complex to the inspectors. Who are the inspectors? These are inspectors are your lymphocytes, classically the CD4 lymphocytes, which are circulating throughout the body, and it will show this antigen to that CD4 T lymphocyte. And the CD4 T lymphocyte will decide whether it is a self or a non-self. So let's look at with the liver transplantation perspective. So you have a liver, there is a ischemic reperfusion injury. Once you have given organ is there inside your body, you reperfuse it. Simultaneously, along with that, your innate immune response starts. So these dendritic cells will take up the antigen from the liver, go to the local lymphocytes, lymph nodes, where the CD4 T lymphocytes are circulating continuously. It will show this antigen to the T lymphocyte, and the T lymphocyte will then decide whether it is self or non-self. It can create cytokines which can promote the B cells. It can create cytokines which can attract more macrophages or dendritic cells to go from the circulation back into the liver to cause inflammation, or it can also simultaneously activate your CD8 lymphocytes, and this process is promoted by release of this CXCL9 and CXCL10, which are adhesion molecules which can promote ingress of more inflammatory cells back into the liver to cause more damage. And the second important concept is, how do they present? They present, we all know, the direct pathway, indirect pathway, and semi-direct. Direct pathway means this pathway usually acts in the first part of your liver transplantation, initial few weeks or months, because you have donor APCs which are present in your transplanted organ. But it gradually fades, and the common pathway for late acute and chronic rejections are the indirect pathway, which will persist throughout your life. But you have to realize that it is not always in the interest of the body to reject an organ. Why would it reject? Unless it is causing some damage to it. So this is the reason over the years in kidney or liver transplantation, the immunity against the transplanted organ gradually decreases. It gradually develops a tolerance for that. Why it developed a tolerance? Because you need, I'll show this later also, that along with this MSC complex, this T cell receptor, they also need co-stimulation molecules. But in the transplanted organs, these co-stimulation molecules levels are low, because they are not the classical antigen presenting cells, the hepatocyte, the biliary epithelial cells, the sinusoidal epithelial cells. So once they encounter without these co-stimulation molecules, it usually leads to, either it will lead to apoptosis of that CD4 lymphocyte, it will lead to anergy, or it may lead to formation of these CD4, CD25 positive, FOXP3 positive T regulatory cells, which can cause tolerance. I'll not go into the details of this, but the last slide, we very well known figure using the signal 1 with the antigen presenting to the T cell receptor. And this, if you have absence of signal 1, it means that cell is blind, that it does not know whether the antigen has actually presented to it or not. And the signal 2 is with the co-stimulation molecules. These are important. I'll show in the studies later also. So this CD28, CD86, and the CD154, CD40 ligand, these are important to ensure that the signal 1 starts acting. And these are the major molecules in which people use immunosuppression, the classical steps that you see. So the next part is, how, if you know about transplant immunology, how do you monitor it? So my title is Plasma Immune Signatures. So I'll not go much into the detail of histopathology. I'll focus on non-biopsy based biomarkers. But before I go ahead, I'll just want to show two things. What are the newer things in transplant histopathology? The two important things are tissue transcript analysis and the multiplex imaging. So this transcript analysis or the gene analysis or the RNA analysis has already been come in the kidney transplantation in their classical criteria of Banff. And they know that once you do this tissue transcript or the RNA analysis in the tissue, you can make out what kind of transcripts are there, and you can try and make a biopsy score and try and interpret whether there is rejection or not. And the second important thing is, so this slide, this is a patient for a transplant. What do you see in this slide? There is a portal tract which is expanded. The only thing the pathologist may be able to tell you that what kind of cells are these, maybe say lymphocytes or say some mixed inflammation or a primary lymphocytic infiltration. But now look at this, same patient. So this is the beauty of multiplex imaging, which is now coming up for the last decade or so. In the same area, you can make out the CD34, the endothelial cells, you can make out the class 2 pattern, you can make out this CD45 positive leukocytes, you can see their APC leukocyte pairing. So if you see this and if you can quantify it, you can tell whether the patient is tolerant or rejecting. Just look at this and compare, the same thing, that's the beauty. And people have shown, this was a study that was done in children also, in which they looked at the quantification of this pairing and this multiplex imaging comparing the tolerant versus the non-tolerant patients. You see the kind of pairing that they could quantify and they could tell. So this helps you that say 3 years, 4 years, 5 years down the line, if you are into that gradual treatment withdrawal, or if you are not even the treatment withdrawal, you don't want to bring the immunosuppression down, you can just do this multiplex imaging and just tell based on these parameters whether your patient is good enough to start withdrawing the treatment.
With this diagram, you have a leukocyte APC pair.
Yes, sir.
So does the number matter? How many will say rejection?
Sir, in this study they did quantify, but they didn't come up with a specific cutoff. But they said in that area the tolerant one had lesser pairing and the non-tolerant one had higher pairing.
On the top, they
Yes,
could be segregated. So I was just wondering if there is a number.
But they in this study they didn't give a number, sir.
Okay.
Yes, sir. The red one is class 2, that is MSC, that is there on your APCs. CD34 is the endothelial cell marker, CD45 is a leukocyte marker, and CD45 plus class 2 plus is the pairing that they could show. So this is the pairing, the highlighted one. So pairing means that APC is now coming up with your antigen and presenting it to a leukocyte. So beyond biopsy, what you can do? So we have gene profiling, we have cytokines and chemokines, we have extracellular vesicles, microRNAs, and donor-derived cell-free DNA. I'll focus on majority of these, and there are some other parameters that have been used. So let's start with the classical immunophenotype and cytokines and chemokines. It's a very mix of anti-inflammatory and pro-inflammatory cytokines. Studies have been done. They have come up with a list of chemokines and cytokines. The more you read it, more you get confused because they don't come up with a specific 1 or 2 or 3 markers which you can use it in clinical practice. That is my understanding of that. But they have shown, they have checked multiple cytokines. But what they have shown is as your transplant age progresses, say from visit 1 to beyond 2 weeks, if you see, the more the yellow is, there is more concentration of these chemokines and cytokines. As it progresses, so that means in the initial post-transplant period, there would be a very high inflammatory state, very high levels of these cytokines and chemokines, which will gradually come down based on your immunosuppression or the body adapts to it and it will come down. So this was a study that was recently published in 2024. What they did, they checked before transplant and post-transplant till 1 year in 250 pediatric patients, checked the cytokines and chemokines level as well as did the immunophenotyping. So what they could find that as I've already mentioned, it is more yellow in the initial part and gradually becomes more blue. This is the heat map, and what they could make out that they could divide these patients into clusters. So there was 1, 2, 3, 4, 5, 6 clusters, and as you can see, the cluster 1, it is predominantly seen in patients who are presenting early, visit 0 that is pre-transplant and visit 1 that is within the first 7 days. So that tells you, and I'll show this later also. So majority of the inflammation, it is happening in the first initial peri-transplant period. And this cluster was associated with high pro-inflammatory cytokines. These are mentioned, and as the age progresses or you go down, say 1 year post-transplant, you see there is the levels of cytokines actually gradually decreases, so body tries to adapt to it. And you can make out that the patient who had this the first cluster, the high pro-inflammatory state cluster, they have lesser rejection-free survival. So if you have higher inflammatory state, you will are bound to develop rejection. So that means you can predict which patients will develop rejection, say next 6 months or 1 year. And another concept they came up with, not a new concept, in those patients who had these 5 and 6 clusters which were associated with better rejection-free survival, they had higher CD56 bright NK cells. So this is a concept which has been known for long. So I'll show this later. So what are NK cells per se? These are part of innate system. They are natural killer cells. So they will kill whatever the virus or tumors they encounter. So they are part of this lymphocyte stem cell, this part. What are these? These are cytotoxic innate cells, and they are divided into 2, tissue based and periphery based. But most commonly it's known as that the tissue based, the hepatic NK cells, they have a higher cytotoxicity, though they are less in CD16 and CD56 low. So what is the concept here is that they have, I'll show this in this way, yes. So this was a study that was done in 2024. This is a summary slide for that. If you can see, day 7 to day 19, that is the very perioperative period, post-transplant, early post-transplant period. The most commonly what they could find that NK cells are associated with increased inflammation and increased risk of rejection. I overshoot my time. So what they could show that this is a trajectory. Starting from day 1, day 7, day 19, day 90, day 65. So as the post-transplant period progresses, the early post-transplant period would see that you would have higher activation of this NK cells and T cells, which is concomitant with your increased inflammatory activity that is there in any post-transplant period. But as the age progresses, this inflammation in the NK cells and T cells will go down. So what this study tells you that NK cells have a role in the initial rejection, which is very common in the initial period. But this NK cells, on the other hand, are also known to cause tissue tolerance. So this is a concept which is used in pregnancy-induced placenta-based studies, in which they have shown that NK cells induce tolerance for the mother to the fetal antigens, which is foreign to her. So what is the concept? People have shown that in the NK cells, in the immediately post-transplant period, there is a increased levels of this NK cells. What I'll tell you what they would do, and these NK cell activity is predominantly seen in your hepatic tissue based NK cells. And studies have shown in patients who develop tolerance, long term studies, one which they have done these studies to show that these patients are tolerant and then go on ahead with immunosuppression withdrawal. They have shown that in patients who are tolerant, the NK cells activity is comparatively higher. And even in patients, if you do the microarray assets, these cell types are predominantly associated with NK gene cells. And how do they work basically? What they work is, once after the post-transplant period, there is an increased expression of these NK cell ligands, which are MICA, ULBP 1, 2, and 3. And what they do actually is, these are the donor NK cells which are present in your transplanted organ. So once they sense that the recipient T cells are now coming inside the liver, what they will try and kill them. So this is the example of the lysis that they do. This NK2 GT2 is the receptor initially, and they would do this lysis in the initial post-transplant period, and they promote tolerance. So in summary, I'll just show this in again way. So you have a hepatotoxic NK cells, which is primarily a donor-derived NK cells. This is the initial peri-transplant period. You have APC, which has presented this antigen to the T cell, and these T cells will now go to the liver cell. But because of the activation, you have increased stress ligands, which I have shown earlier, MICA and ULBPs. So what the NK cell will do, it will attach with this ligand, and it will try and kill any alloreactive T cells that it can encounter. So it decreases the inflammation and promotes tolerance in the initial period, and then subsequently using this perforin granzyme or the apoptosis, including the death receptors like TRAIL. Second important concept is, we are all aware that these are the NK cell receptors. These are the activating receptors, and these are the inhibitory receptors. So once you PD L1 and 1, they decrease this inflammation. So we are all very aware of this PD1, PDL1, this immune checkpoint inhibition that the chemotherapy or the oncologists use very common. So so this is important in transplant immunology also. So PD1, PD-L1 are inhibitory receptors. Once they interact with each other, they will not let the cell to proliferate. But if you can inhibit these using this anti-PD1 or anti-PD-L1 immune check inhibitors, it will allow T cell to work against the tumor cells. So this is a concept which they use in oncology. But how can you use it? So the corollary of this is, once you use these immune checkpoint inhibitors, there is a higher risk of graft rejection if you are using it in a post-transplant patient. Why it happens? Because it will allow this affected T cell to kill the lymphocytes, but simultaneously these T lymphocytes are now activated. So there is almost a 2 to 5% risk of rejection after organ transplantation once you are using these immune checkpoint inhibitors. So corollary is, how can you use it? So rather than inhibiting it, if you can do something to promote this inhibition, say you can induce the expression of this PD-L1, it can decrease the inflammation and it can cause this activated T cell apoptosis and it increase the graft survival. Now another concept is, which I did not understand in this study, if you use these checkpoint inhibitors, something like checkpoint inhibitors pre-transplant, not post-transplant, because of this inhibition of this donor NK cells which are present in the graft organ, it can lead to killing of the recipient alloreactive T cells. I not understood this concept, but so if you can do something pre-transplant, you can actually decrease the risk of rejection post-transplant. Another concept is memory T cells. We are all aware that you have a naive T cell which forms the effector T cells and then goes ahead to form the memory T cells. And these memory T cells are better than your effector T cells because they do not require these co-stimulation molecules and they have higher expression of these adhesion molecules which are LFA and VLF4, which allows them to mount an increasing or higher or more profound immune response once they encounter that infection, the antigen alone. So this concept, this CD154, I showed this previously also. This is a ligand to this CD40, which is also present in your memory T cells, and it is primarily expressed on activated T cells and also on memory T cells. So this is a only FDA approved marker for post rejection monitoring till date. That's the only thing I'm aware of. These are actual patient reports. So if you can look at this donor induced 154 T cell memory cells and used with the third party induced, you calculate this. If it is more than 1.1, there is increased risk of rejection as shown in this patient, increased rejection because the immunoreactive index for 1.5. So this was developed in Pittsburgh and they are using it as the only FDA approved thing that I could aware of. Or you can do some other markers. This is another study in pediatric liver transplant patient. They used these these markers and calculated a score based on that and showed that it is a marker for rejection. Second part is, you can do the gene analysis. You can come up with another signatures of the entire gene, create a gene panel. Multiple gene panels have been used and they all show that patients who are tolerant, they have lesser amount of this inflammatory gene pathways which are working. Another important complex is proteomics and metabolomics. I'm not very clear about these, but these are that you calculate some proteins and some metabolites like C41 in this study in 2011, they could find that it had a good sensitivity to predict rejection. And or you can do a proteoform. Proteoforms are nothing but more higher forms of proteins that I could understand. You can do this LC-MS-MS and come up with, in patients who are acute rejection or not rejection, or in a transplant patient, you can come up with a similar molecules or the proteins. You can show that these levels, if they are high or low, can predict rejection. And this was another study that was published 2 years back in Science. They created an entire atlas based on the blood proteoforms, and what they could make out similar results as the previous study in patients who are tolerant versus patients who are rejection. You can make out which proteoforms are higher or lower in these groups. And some other metabolites they have used, bile acids and diesters. So these are there. Second important concept is EVs. Courtesy Dr. Sukriti, she had taught me this. So EVs are nothing but cell-derived membrane-bound vesicles which are present, and body is continuously releasing them, especially when they are facing a stress or a death or some other thing. And what they tell you, they are nothing but a proxies of cell of origin. They carry your genes, they carry your antigens, whatever. So if you can collect them, you can quantify or study them, you can make out where they are coming from. And studies have shown that these are in patients who are rejecting the EVs, CD31 or CD8 positive or CD4, these microparticles or EVs are higher in those groups. And they have shown similarly, they have shown that, so these markers that they use, annexin is a common marker for EVs, and acylglycoprotein receptor are common hepatocyte specific, and CD130 and connexin 343 are predominantly for the inflammation. So in those patients who are rejecting, they have higher levels of these EVs, as have been shown in multiple studies over the world. Concept is donor-derived cell-free DNA. I'm very much excited about this because it looks more simpler to us. So what is donor-derived cell-free DNA? If your body is rejecting, rejection means it is attacking your transplanted organ, which is donor in origin. Once it gets injured, it will release more of its DNA to the blood. So if you can quantify it, this donor-derived divided by donor plus recipient-derived DNA, you can come up with a specific percentage. And this study, in this they have come up with specific percentages. Some studies have been shown good sensitivity and specificity, and have shown that patients you can find out classical thing, that you can find out that they are not rejecting or not rejecting. And you can always also differentiate with respect to other secondarily graft injuries like EBV, CMV or drug-induced injury, and they have shown that it can precede the actual rise in your AST, ALT or SAP and GGT. You can predict which patient is going to reject if you follow them monetarily. And it can show this is day -100, day -50 and day of biopsy. Even till the date of biopsy, the SAP and AST, ALT have not risen, but the donor cell-free DNA could predict rejection. And this was a study that was published recently from Chennai, in which they have come up with a cutoff of POD7 more than 10.2% in patients who are rejecting versus not rejecting. So looks more simpler to non-immunologists like us. Last aspect is microRNA. MicroRNAs are nothing but non-translated RNAs which control your gene expression and cell fate. So they are produced from the same pathway as mRNAs, and studies have shown they have come up with multiple numbers, 483, M1222, more hepatocyte specific, which are associated with acute rejection. And so they come up with most commonly ones are used are 155, 483 and 122, which they have come up with in patients who are rejecting. So the higher the levels of these microRNA, higher is the risk of rejection. So if nothing else works, you can go back to machine learning. As have been shown, Dr. Mamta Bhatt was here, she showed this paper here, and you can come out with the multiple algorithms to tell you which patient is going to reject, which patient is not going to reject. So to conclude, for non-immunologists like us, I would feel that donor cell-free DNA, RNAs or EVs are the future, but in the expert hands, you may also look for chemokines, cytokines and proteomics, but I'm very much interested in multiplex liver biopsy imaging if it can come up at ILBs. Thank you so much, and I'll be able to take any questions.